neurogenic bladder. So we're still in the concept of elimination. Neurogenic bladder, bladder problems due to a disease or injury to the central nervous system, or nerves that involve in the control of urination. Conditions interfere with successful bladder control. So the sympathetic stimulation is predominantly the process during bladder filling, and the parasympathetic is the causes emptying. So the bladder expands as urine flows from the ureters into the bladder, but there is a limit to how much your bladder can hold, 300 to 500. But about 200 mils of urine, you're going to get, your muscles are going to begin to contract, and the internal sphincter is going to begin to relax. And this sends a message to your nervous system and creates the urge to urinate. If this urge is ignored, continence may be threatened. And at about 500 mils, your muscles are going to contract and force open the internal sphincter. So then it's the fight kind of between your external and your internal sphincter as to whether or not who wins out. But if the internal wins out, then you're going to be incontinent. Okay, so that's how it works. The more when the muscles expand, sends the impulse to the spinal column, brain to say time to urinate. In the neurogenic bladder, that pathway is not working. And according to where the injury or the illness is, it causes different problems. An overactive bladder related to the upper motor neurons results in incontinence, unable to completely, and even with that incontinence, because it is not the normal way, you may have a reflective incontinence of your bladder just operates without having that brain impulse of holding or not holding. So they're having incontinence, but it's not effective. So a patient's not going to be emptying their bladder effectively, and they're going to have residual volume, which is going to have them at an increased risk for infection. But in the neurogenic bladder, you have a loss of communication between your spinal column, your brain telling you when to go and when not to go. So you can, according to where the injury or the disease process is involved, will make it either overactive or underactive. So there are two types, mainly two types. One is the incontinence is due to, in the uninhibited, overactive, or spasmic. It's usually an upper neuron, motor neuron injury, and that is above T4 or T12. So what happens is your normal spinal cord reflex is still intact, but there's no connection between that point in your brain to control it. So at that point in time, your urination becomes totally a reflex. That signal gets sent to the spinal column to say, you've got to go, but your spinal column doesn't have a path to take it to the brain to say, is it time to go? I need to go, but is it time to go? So there's a difference. You have that loop. So you still have that total reflective reflex action. That's still intact because the break is above T12. But the message of controlling is it time to go is wiped out. So what happens is that the impulse gets sent and it says, I gotta go, and your spinal column sends back the message of, it's okay, go. So they don't have any control over when they go. It's purely when their bladder gets distended, that reflex of going is gonna happen. So they're gonna not have the ability to control it. The other piece of that is if you have a lower, an areflectic reaction is underactive or flaccid, everything acts like it is paralyzed. And when that happens, then you have retention because that reflex arc is not intact. Kick me out. Back up, okay. So the uninhibited reflex spastic bladder, there's no influence of time or place to void. The bladder contraction and the sphincter relaxation is it's not coordinated with the brain when it's time to go. Causes are, if you will have a spinal cord injury above T12, can happen with stroke, can happen with brain tumor, can happen with brain trauma, lots of things. Manifestation, normal volume, or maybe a little smaller volume. An overactive bladder that results in incontinence, frequency, urgency. Voiding is unpredictable and incomplete. So the bladder fills with urine and stretches, and the stretching bladder, acting like it normally does, sends out that impulse by nerves to the spinal column and say, we gotta go, we're stretching. And the message loops around because now it's cut off from the brain. It loops around below the injury and sets up the reflex, and then the message is sent back to from your spinal cord to your bladder. Bladder then contracts and urine's let out. It can be an inconvenient time because the brain is not in that loop to determine the right time. Everybody understand the spastic route of why that happens the way it does. So this is incontinence. Even though they're incontinent, it's not really a effective or normal urination, so they are going to have post residual volume because it's not a complete incontinence, and that gives them increased risk for infection as a result. The areflectic is flaccid. Everything acts paralyzed. That loop to the spinal cord is not there. That reflex arc is not there. So basically, the impulse is still there in the bladder. It's still working just fine. The impulse is still there, but it doesn't have any place to send it because it's cut off. It's not working either. It's a lower motor neuron injury below, usually S2 to S4, lesions on the brain, pelvic nerve issues, but that whole pathway is completely cut off. So your bladder is still working fine. It's still getting distended. It's still sending out impulses, but the impulses are not picked up. They're not being received. So what happens? That impulse is because that impulse is sending a message to the spinal cord that's not receiving. We need to go, we need to go, we need to go. But your bladder is not getting the message back to go. So what's going to happen? Retention, because it never gets that message to release to urinate. So you're going to have an overdistended bladder, and then you're going to have incontinence from the leakage from your bladder is not urinating, but there's a leaking. As it gets full, you're going to have a distended bladder and an overflow incontinence. Again, you're going to have urine sitting in your bladder, and there's going to be a risk for infection and UTI. Going to have lots of bladder accidents, only because when the bladder becomes too full and it can't hold anymore, or it's gonna leak out. Leakage in small amounts of urine frequently throughout the day and night. Frequently small amounts. The bladder is distended. Risk for skin integrity issues, risk for infection. Diagnostic tests, history and physical. Bladder diary, pad test is you wear a pad that changes colors whenever you leak urine. UA, culture sensitivity. Bladder scans to see for residual. Again, you do urine, creatinine to see how kidneys are functioning. X-rays, CAT scan to see, get an image of spine or brain to see if there's something else going on, underlying condition. Diagnostic tests, the urodynamic test shows how well your lower urinary tract is storing and releasing urine. The EMG also is testing the strength muscles used in voiding. In the cystometry, we are looking for problems with filling and emptying the bladder. Measures the amount of urine in the bladder. Does involve looking at how the muscles function, the mechanics, the nerve response. Does involve a urinary catheter. Is needed temporarily in the procedure. Patient voids, and then the catheter is inserted to measure the residual volume. Then they instill water to see how much your bladder can hold before you get those urges, and before you get the urge that I can't hold another drop. Complications of this is a urinary tract infection because they had a catheter put in. Autonomic reflex of severe headache, increased blood pressure, low heart rate, sweating, and flushing. Urethral pressure profile is it's just information about how the urinary incontinence and urinary retention. It manipulates the bladder neck, measures the amount of pressure at each of those points along the way, and while the bladder is being distended, is fluids getting instilled in there to measure those different pressures. Afterwards, it does include the catheter as well and monitor the patient for UTI. Management is based on education, patient teaching, bladder retaining or retraining, fluid schedule, indwelling catheter, drug therapy, surgical therapy if needed. The uninhibited management is treatment of the underlying cause if possible, bladder decompression, intermittent self-catheterization, facilitating techniques. Facilitating techniques are used to stimulate voiding. You're kind of like trying to bypass that reflex arch that's not there. So sometimes if this works, it doesn't work on everybody, but you use or something to stimulate voiding, like stroking the medial aspect of the thigh, pinching the area above the groin, pinching the posterior aspect of the glans penis, digital stimulation. Sometimes those sorts of things can cause the reflex action to void. Bladder augmentation is also used to make the bladder larger so it holds more, decreases the pressure, and makes the bladder itself more elastic. Drugs, Botox, anticholinergics like diazepam, amitriptyline, antispasmodics, mainly looking to suppress the contractions, suppress the spasticity, calm the bladder down so you don't have so much incontinence. electrical stimulation as an attend unit to stimulate the bladder. The aeroflexic urinary catheters used to depress the bladder. The crate or Valsalvo maneuver. Intravaginal device to support any prolapse that's occurred. The Valsalvo maneuver is when we ask our patients to hold their breath and bear down like they're trying to defecate. Should never use this maneuver on a spinal cord injury person who is at risk for bradycardia due to loss of vagal nerve control. Can't use it for those patients. The Craig maneuver is placing a patient's hand, a cupped hand, over their bladder area, instructing them to push the inward and down as if massaging the bladder to empty. Also taking alpha adrenergic blockers such as tyrosine, cholinergics such as ethanol. All of these for urinary retention. Consistent scheduling of toileting routines is very important. Time voiding, helping get them back on a schedule will help, as well as intermittent catheterization if they're having a lot of residual. So you may start doing bladder training, but having to do straight cath intermittently while you're doing the bowel training, and then as your in your urinary training, as that retraining takes effect and starts working, then the residual might be less and less. So then instead of having to cath them every 4 hours or 2 hours, you slowly increase the time. But usually you do cath like every 8 hours if they have a residual. But hopefully with your training and retraining, that residual is going to be less and less and less. So the number of times you have to cath will hopefully go down. Also, urinary diversion may be a procedure that's used, especially for treating bladder cancer or some congenital abnormality or result of strictures or trauma, something like that. There are continent urinary diversions, which is controlled by a sphincter, and they catheterize to empty it, and the incontinent, they will require them to wear a device. I don't know how much experience you have with any ostomy supplies or any ostomies, but what's the hallmark thing that you have to take care of in an ostomy? The stoma, and what else? Excoriated skin around the stoma is just, you have to really protect that area, because once it gets broken down, how easy is it to fix? My heart has broken so many times when I've seen just the terrible state of some people's skins around stoma. So skin care is so important. Management of the urinary diversion is discussing the psychosocial aspects of having a stoma. It's what's one of the things that the patient has to deal with? What's one of our main diagnoses with someone going to get a stoma? Body image, right? There are huge body image issues that you need to have them communicate and vocalize. Changes in clothing, changes in our body image, sexuality, exercise, how to deal with the odor. Teach with the continent diversion to catheterize at least every 6 hours and to irrigate daily. They need to have a referral to wound or ostomy continence nurse. Postoperative, prevent surgical complications. MPO status, NG tube, prevent injury to the stoma, maintain the urine output, advise the patient that the mucus in the urine is normal, encourage a high fluid diet to flush the ileal conduit, provide meticulous care of the skin around the stoma. That is a daily battle with patients that have diversions. Urine is kept acidic to prevent alkaline incrustations. Other skin problems include yeast infections and developing an allergy to the products. Also changing the appliances. We want the appliances to fit properly. The appliance should be about 0.1 centimeters bigger than the stoma. Why do I want a stoma this size and then my hole I'm cutting for my appliance this like that? You're gonna have everything in that skin. So you want it as close to the size of the stoma as you can possibly have, because that protects your skin, the patient's skin. It is normal, and the other thing is you have to measure, especially a new stoma, because when they first come back from surgery, like all surgeries, it's a little swollen. And if you measure that stoma when they come back from surgery and it's one size, and you keep cutting that size, what are you gonna eventually do? It's not gonna fit, is correct, and it's going to open up their skin for what? Because it shrinks. So if you're cutting the same hole size just because that's what you measured it one time, especially after surgery, you're gonna end up having they're gonna have really horrible skin problems. So after surgery, it's going to shrink over the coming weeks. So you have to constantly keep reassessing the size of the stoma to make sure that your appliance is fitting correctly to protect your skin. Medications you're going to, you guys will refer to your ATI, not to Lenny. The other class has Lenny, so, okay? So it would be your ATI is what you're gonna refer to for your.
We have both.
We have both of them.
You don't have Lenny?
Yeah.
Not everybody do.
How many has Lenny? Because I was told you didn't have Lenny.
I was told it was a requirement. Yeah.
Because I spent a whole lot of time going through stuff, marking off Lenny, because I thought you didn't have it.
Most of
Some of you do.
some of us don't.
Okay, well, I was told that you didn't have it, so if you have it, you can refer to it. Lenny is, ATI gives you good info. Lenny's very technical. I guess that's the word I would. It's a very technical book. It gives all the information you need, that and a lot more. But ATI also gives as well. So either one you can refer to. It's just, I was told you didn't have it, and that's why, yeah. I didn't know that some of you had it. Go figure. Okay? Any questions?
Can we take a little break?
I was hoping to give you a break before your test. So you, okay, I'm hoping to get through so that you'll have a few minutes before the test is gonna start at 10:30, okay? If you need to go real quick, I can give you like 2 minutes real quick or something. But I wanna give you a little break before your test so you can get kind of prepared.